President Research and International at the University of Waterloo. The University of Waterloo acknowledges that much of our work takes place on the traditional territory of the neutral Anishinaabe and Haudenosaunee peoples. Our main campus is situated on the Haldimand Tract, the land promised to the Six Nations that includes 6 miles on each side of the Grand River. Our active work toward reconciliation takes place across our campuses through research, through learning, teaching, community building, and it is centralized within our Indigenous Initiatives Office. I'm really pleased again to welcome you all to this first event in a series called A Year of COVID-19. What a tremendous year we've all experienced. Today's event is focused on disparities, inequities, and inequalities that have existed for decades and centuries and have become even more apparent during the last year. We'll hear from a number of experts in medicine, in research, in health promotion, with experience working with the people of Waterloo region, across Canada, and internationally. We will begin with a keynote speaker and an opportunity to ask questions of the keynote before moving on to a panel session. At the panel session, each panelist will present a short talk, and then we will take questions from the audience. Please add any questions you have anytime throughout the event today to the question and answer chat line. We're also recording the full session, which you'll be able to find on the President's Anti-Racism Task Force site. I'd like now to invite Jean Becker, our Senior Director, Indigenous Initiatives at the University of Waterloo, to introduce our keynote. Jean?
Thank you so much, Charmaine. Welcome, everybody. I'm so happy to have all of you with us today, and I am so pleased to have the opportunity to introduce Dr. Wyman. Dr. Wyman, we're very happy that you agreed to speak to us today, and I just want to say to you that I hope you know what an inspiration you've been for Indigenous people, particularly for women, and that personally I've followed your career for many years, and I'm so very, very pleased to have this opportunity to be with you today. Dr. Cornelia Wyman is the acting Deputy Chief Medical Officer. She is Anishinaabe from Little Grand Rapids First Nation, Manitoba. Dr. Wyman completed her medical degree and psychiatric specialty training at McMaster University. Canada's first female Indigenous psychiatrist, Dr. Wyman has more than 20 years clinical experience working with Indigenous people in both rural, reserve, and in urban settings. Her previous activities include co-directing an Indigenous health research program in the Dalai Lama School of Public Health at the University of Toronto and the National Network for Indigenous Mental Health Research, being Deputy Chair of Health Canada's Research Ethics Board and serving on CIHR's Governing Council. She has also worked and taught in many academic settings, has chaired national advisory groups within First Nations Inuit Health Branch, Health Canada, and has served on many boards and committees, including the Inspire Foundation's Board of Directors. Dr. Wyman is an adjunct professor in the Faculty of Health Science at Simon Fraser University and an assistant clinical professor at McMaster University. She has recently been re-elected to a second 3-year term as president of the Indigenous Physicians Association in Canada. Her specializations are mental health and wellness, addictions, trauma-informed practice, cannabis communications, and wellness initiatives. Welcome, Dr. Wyman.
Thank you very much, Jean, for that introduction. And hello to everybody. Ani Boujou. Before I start, I just would like to share my screen. So I will accomplish that successfully, I hope. There. I'm hoping that people can see that screen. Great. That's the most stressful part of this morning over with already. So again, thank you to the planners and to the University of Waterloo for inviting me to share what the past year, the year of COVID, has been like from where I sit. And I specifically retitled or added to the title of this session, Disparities, Inequities, Inequalities, and added, and Resilience, because that's part of what I'm going to tell you about today. This beautiful picture that's part of the title slide is a picture of vaccines being delivered to a remote First Nation in British Columbia, where I currently live, work, and play. And so I'll be sharing a lot of different pictures and artwork over the next few minutes. Before I start, I will give my own land acknowledgement of where I'm situated. This is really an important thing to do, to center ourselves from where we are. I am Indigenous, not on my ancestral territory, and I respectfully acknowledge the land on which I work, live, and play is the traditional, ancestral, and continually occupied territory of the Coast Salish peoples, including the unceded homelands of the Musqueam, the Squamish, and the Tsleil-Waututh nations, otherwise known as Vancouver, and it's great for me to be here with you today. I'm going to give a little bit of an overview. Since the title of this whole series is The Year in COVID, I'm going to just give a snapshot picture of what it's been like over the past number of months for First Nations and Indigenous communities in Canada regarding COVID-19. So as of a couple of days ago, we had about 1.15 million total cases of COVID-19 in this country, with over 23,700 deaths. For First Nations, and this data is specifically for people who live in what we call in community or on reserve communities, we have had a total of 26,392 cases as of April 20th, and total number of deaths, 305 individuals. And when we say numbers like this, we don't just mean numbers, we mean people, of course, people and families and communities that have been affected by COVID-19. And I think part of what we're here to talk about today is how some of these different communities already disadvantaged in different ways have had to contend with the global pandemic, but how it plays out in their own communities. And what you see now in the chart that's in the middle of the slide were our active COVID-19 cases by week, starting on the left-hand side from around July 2020 last year to just recently, April 18th, 2020. And what you see around the time of January, late December, January, is this peak in our curve of active cases, followed by what we see going into the spring up until this past week, a decline in the number of cases. And much of that is due to vaccine distribution in communities across the country, including in British Columbia, where I work. As was mentioned, I'm a psychiatrist by training, and actually did my bachelor and my master's degree at the University of Waterloo before I went to medical school. But now, after 20 years of practicing as a psychiatrist, I moved into public health about 3 years ago. So just in time for a global pandemic to hit. So things have been very busy over the past year. And as you can see in the bottom of the slide, one of the reasons why this curve has come down is because, as I mentioned, the vaccines have come out, and you'll see pictures here of the vaccines actually being kind of brought into the building with ceremony in the community on the right. And the numbers that I talked about as being people, these are our elders we're talking about. These are people who are knowledge keepers, cultural resources in our community that we have lost to COVID over the past year. So vaccinating our elders especially has been a primary concern over the last year. So much of my life over the last few months, since Christmas time, I guess, has been being involved in the vaccine distribution. And in Canada as a whole, we have distributed more than 13 million vaccines. About 11 million of those have been administered. In First Nations communities, we have delivered almost 350,000 vaccine doses, with about 90,000 of those being second doses. And the reason why the second doses have been given is related to people's, the location of communities being remote or isolated, so that they can't easily access medical services, for example. So we have made sure to go back and make sure that those communities have already had their second doses. And as everyone here on at the event knows, we are now, Canada's in our third wave. Transmissible variants of concern are continuing to spread. More severe courses of illness, including in the younger populations. And some provinces, of course, are doing a bit better than others in terms of their public health response. And why I can say that, you know, there was a period of time over the past year where the proportion of COVID deaths was overrepresented by Indigenous people. We have now, our total cases and deaths are lower than the general Canadian population. And in part, that is because of the vaccination effort over the last several months. And because the topic today is talking about disparities and inequities, one reason why this has happened, why Indigenous people have actually been prioritized this time around, is because of advocacy that has happened. And in no small measure, it's partly, I think, related to some pretty severe episodes that have happened over the past year that have drawn people's attention to racism and anti-racism. The murder of George Floyd in the United States, the death of Joyce Echaquan in Quebec in August of last year. I think this has really brought these discussions to the forefront. And so it has allowed us to step into some places in certain instances and strongly advocate for equity. So for example, the National Advisory Committee on Immunization came, you know, they were having discussions around their guidelines before the vaccines actually arrived in Canada and were approved. And, you know, myself and other Indigenous physicians, public health specialists, advocates, strongly advocated for Indigenous people to be recognized as a priority group. And so they were included in the phase 1 or stage 1 of vaccination. And in British Columbia, we have tried to adhere to what's called a whole of community approach. So rather than just going in and vaccinating 80 years and older, we have in many cases offered the vaccine to whoever's eligible that was 18 and over, as a way of protecting that whole community. And in urban populations and elsewhere across the country, there have been other people who have been really strong advocates, including 2 of my Indigenous physician women colleagues, Dr. Janet Smiley and Dr. Lisa Richardson. So I raise my hands to them here today. Some of the impacts, I don't think I need to spend too much time on this slide, except to share that, there has been a great deal of unpredictability and uncertainty for all of us, including Indigenous populations. How long is this going to go on? How long are we going to have to live like this? What's happening with these variants of concern? Things like that have really risen people's anxieties. And that feeling of loss of control over your lives, over all of our lives. When can we socialize with people again? When can we visit with family due to the public health measures? For Indigenous people, there is also that history of past pandemics, past outbreaks, and trauma associated with that. And I'm thinking of things, for example, not just like smallpox, but the H1N1 flu outbreak in 2009, when body bags were sent to communities in Manitoba as part of a public health response. And there are other social determinants, what we call social determinants of health, that have impacted both people's experience of COVID-19 and the impacts of it and the response to it. So for example, when we talk about vulnerabilities, we have situations, for example, where we have multi-generational families living under the same roof, different economic and work-related issues. Access to healthcare was a big one during this pandemic. So communities that were 2 hours or more from being able to access health facilities were considered at particular risk. And just the public health measures around socially isolating. So there's been a lot of disconnection. People haven't been able to visit. They haven't been able to conduct family events such as funerals the way that they were before, participate in ceremonies or traditional healing. And racism has played a role during the pandemic, that's for sure. I've just included kind of a smattering of headlines, but people have experienced racism at all aspects of the pandemic and the public health response. So for example, people have been really reluctant to go for testing because of how they fear they will be treated. And contact tracing, for example, is another one. So we've experienced situations where people have been reluctant to disclose the entire nature of their contacts and who they've been with for fear of how they will be treated. And the responses of outside communities to clusters and outbreaks in Indigenous communities. So for example, here in British Columbia, there was an outbreak near Tla'amin First Nation, which is on our Vancouver coastal region. And once it became known that cluster of cases had arisen, the local grocery store banned anybody from that community for accessing food in that case. And another case occurred in Cowichan where there was an outbreak. They're a fairly large community or groups of communities, and surrounding businesses were not allowing people from those communities to enter their premises. And of course, now we have heard, some negative blowback and with racist tones for sure around access to the vaccine. So something that we advocated so hard for because of inequities, we are now experiencing racism because we have been one of the priority groups to access the vaccine. Another thing that has happened during this year has been this confluence of what I call 3 public health emergencies all at the same time. So we have the COVID pandemic, we have the worsening of the opioid crisis because of the public health measures, and we have anti-Indigenous or just racism in general. In British Columbia, we in some ways are fortunate that we had a quite extensive provincial review of our healthcare system most recently. In December, November and December, Mary Ellen Turpel-Lafond, who's an Indigenous lawyer and activist, was tasked with exploring racism in BC's healthcare system, specifically anti-Indigenous racism. And she found, her team found that racism is widespread. It limits access to health services. It disproportionately affects Indigenous women and girls and has been magnified by the public health emergencies. And in addition, one of the major findings was that Indigenous healthcare workers in the system themselves experience racism. And there were 24 recommendations. You can find the full report in the links on the right-hand side of my slide. One of the major recommendations was an establishment of a provincial task team to propel the recommendations forward. So I am a member of that task team, and we are about to start our work together in a couple of weeks. One of the biggest sort of nuances or pleas from this report was to establish a speak up culture, meaning that if you witness it, you experience it in the healthcare system, people are encouraged to speak up about it so that it's no longer kept in silence or ignored or denied. As far as our public health response to COVID-19 here in British Columbia, I mean, it has run from the very typical, so providing PPE and other supplies, setting up community-based testing because of what I talked about earlier, people not wanting to go out of the communities for testing because of the way that they fear they will be treated, culturally safe contact tracing, isolation for those in supports, and of course distributing the vaccine. So here you'll see a smattering of pictures of what we've been up to during the pandemic. The slide in the middle on the right-hand side shows kind of an Indigenous specific vaccination clinic where people are greeted with culture and ceremony as a way to try to make that experience safer for people. We have regularly communicated with communities through webinars, community meetings, the media. There's been a switch to virtual services and a creation of new services that will be legacy pieces once the pandemic is over. So we've set up a primary care virtual service in British Columbia, as well as a virtual psychiatry and substance use service, which will remain in place after the pandemic winds down. And this will provide access to services that people didn't have before. We've also spent a lot of time the past year doing public health messaging. You see a few examples here on the slides. Doing webinars around the vaccines and safety, trying to build vaccine confidence. And I would have to say, to a fair extent, I think we have. We have pockets of people who are hesitant, but we have had wide acceptance of the vaccines as they have rolled out. And the last thing that we do, and that's kind of been a fun part of the job, if I can say that any part of this last year has been fun, is using our Indigenous strengths and inherent resilience to overcome some of these disparities and inequities. This is a very short presentation, so I'm not able to sort of describe here in BC how we have a unique relationship with the provincial government, the provincial Ministry of Health, and our regional health authorities. We have a provincial First Nations health authority that works for BC First Nations communities and helps them on their self-determination pathway. And that includes initiatives during the COVID-19 pandemic. And so some of the initiatives that my team or our team that I work on has been involved in is not just focused on the Western public health measures that I've talked a little bit about, the vaccines, contact tracing, things like that, but initiatives that bring to the forefront our Indigenous strengths and resilience. And we started an initiative early on in the pandemic called the Good Medicine Initiative. And there are 4 different categories that communities or individuals could participate in. One was being wellness champions, so showing other people how they were working on their overall wellness or mental or physical wellness during the pandemic. some of the other ones were using our Indigenous strengths. One of our major coping mechanisms is our sense of humor, I believe. And so we've had a number of sort of silly contests over the past year. Like, for example, we asked people to send in pictures of their do-it-yourself haircuts, and the inevitable disasters that have happened when people have done that. And it seems really silly on the surface, but seriously, try to remember for all of us the last time that we really laughed deeply. We really laugh from our spirit. It's been an incredibly challenging year for everyone. We've also provided opportunities, for example, to have our elders conduct ceremonies, not just outdoors, as you see in the picture on the slide, but virtually as well. And that's been a whole new challenge. It's a completely different way of thinking that we didn't have before. Prior, it would probably be, I wouldn't say inappropriate, but verging on very unusual to ask an elder to do a traditional opening by teleconference, for example. And now having elders participate, opening and closing our meetings and gatherings in a good way with a traditional song or teaching has now become quite routine. So I think I will end there. I know I've gone maybe a little bit over time, but what I wanted to leave you with is that, dealing with something like a global pandemic has forced us in some ways to become aware of disparities, communities that are at risk, and inequities, and how that relates to more severe outcomes. And that's definitely, we've talked about widening the gap, or narrowing the gap that is already wide because of these disparities. And I didn't have time in this presentation to talk about the effects of the opioid crisis, but we have lost more First Nations people due to the opioid crisis in the past year than we have to COVID. And it's because, I think, in part, the thinking around COVID is chaotic as it has been, is this, underlying messaging that we're all in this together, when we're not really, but that's the messaging. And when it comes to something like the opioid crisis that disproportionately affects Indigenous people and at-risk populations, the messaging is, I'm glad it's you and not me, or that has nothing to do with me. So we have a lot of challenges going ahead, and the recovery phase from this pandemic is still going to be a huge challenge, and go on, I think, for a lot longer than we think. But at the same time, that can afford opportunities. So I want to thank you for your time and your attention today, and I'm happy to answer any questions. Che Miigwech.
Thank you so much, Dr. Wyman. That was really wonderful. Thank you. The first question we have for you is, what actions can the university take to support its Indigenous students, faculty, and staff, given the impacts that the pandemic has had on the Indigenous community?
Okay, so I just want to make sure that I'm understanding. What can the university do?
Yes.
I think there's probably some specific things and some more general things. I mean, for example, when we're talking about anti-Indigenous racism, which is a big part of the pandemic, institutions or organizations like universities have their part to play in that. Just as I was speaking about the In Plain Sight report, there are recommendations in there for universities and post-secondary institutions to create that safe space to, as much as they can, to eliminate racism, to create that speak up culture, and of course, support their Indigenous or racialized students and members. you know, it would be a whole different presentation to talk about what it's like to be an Indigenous or person of color faculty member at a university. And I'd like to say that I hope things are getting better over time. I hope they are. But, you know, I'm sure other people coming up on the panel can speak to some of the challenges that they've faced. So, you know, that the university level changes needs to also come from the leadership. You know, I think students, our Indigenous medical students are amazing. But what we found out over the past year through a project they did was, you know, there are people who are in senior leadership positions at universities who think they're doing something on anti-racism or reconciliation, but it's not actually getting down to the students on the ground. So the other suggestion I have is for that real line of communication between, you know, top leadership, senior executive level, down to the grassroots, to the students who actually attend those institutions and actually hear what they have to say. Thank you.
Thank you. Thank you so much. That's a great answer. I'll make sure I read that report. The next question is, how can I be an ally to the Indigenous community, especially as a person with privilege who has benefited from our current systems?
Well, I think, first of all, thank you for that question. And I think identifying oneself as an ally is really important because we need our allies. I don't think we're going to make much movement on racism or anti-Indigenous racism or anti-Black racism without those allies and partnerships. In many cases, we still haven't kind of infiltrated to those higher levels of power. So to really make change in systems, we need those allies. There are a huge number of things that someone can do to become a better ally. There's lots of books to read. There's, you know, conversations to actually have, but also being aware that some of that learning, you know, needs to be self-directed. One of the things that, you know, for example, myself or Indigenous medical students identify is we are often asked to be sort of the cultural tour guide for people who are interested in become, you know, being better allies. And I don't mean to sort of close that enthusiasm off, but that's an extra burden that sometimes we shouldn't have to carry. So there are, you know, there's cultural safety training that one can take. There's books that one can read. There's all kinds of resources out there. I gave a talk on this actually 2 days ago to the psychiatry group at BC Children's Hospital. So it would be too long for me to sort of capture it in this answer, but I encourage people to be better allies and be better informed to start with. Thanks.
Thank you. It's a great answer. The next question, when it comes to the opioid epidemic, has the pandemic increased this because of mental health struggles?
Thanks for that question. I mean, I think it's multifactorial. So one of the other major one of the major public health emergencies that I work on here in British Columbia is the opioid crisis, as was mentioned. We have actually changed the terminology over the last couple of months from opioid crisis to the toxic drug poisoning crisis, because it's clear that the majority of deaths are because of the incredibly toxic and poisonous illicit drug supply. And what ended up happening at the beginning of the pandemic was this incredibly, you know, this collision of people who use substances, but trying to comply with the public health measures put in place. So everything went into lockdown. And what that meant was overdose prevention sites closed, treatment centers closed, a lot of the counseling and harm reduction and support services closed. And so those have sort of gradually reopened or on a virtual basis, but the outcomes, the negative effects on people who use substances is one of the most glaring unintended negative consequences of the public health response to the pandemic. Like I said, in British Columbia, the opioid crisis has been going on for 5 years now, and 2020 was our worst year ever in terms of deaths due to toxic drug poisoning. So where we were starting to see a decrease in deaths in 2019, all of that progress seems to have evaporated because of the pandemic and the toxic drug supply. So as I mentioned right at the end, I think we really need to change how we look at the toxic drug poisoning crisis, because there's so much stigma there compared to the COVID-19 pandemic. And even the COVID-19 pandemic has stigma associated with it. So there is so much more work to be done. Thanks.
Thank you. I have a follow-up to that question. How do we raise awareness of the opioid crisis to ensure ongoing action to address it?
Well, I think, I think people know about the opioid crisis for the most part, but it's what I was trying to get at the very end of my talk is, how do we get people to care, right? A lot of people really do feel like, oh, well, this isn't really my problem. Or I would like to see this negative group outside of my neighborhood, that NIMBYism that we hear people talk about. I mean, I live here in downtown Vancouver, and the neighborhood right next to me is the real downtown piece of Vancouver. And they moved people at the beginning of the pandemic into the city of Vancouver bought hotels and changed them into single room occupancy housing for people, often who use substances. And the outcry from the neighborhood where I lived was embarrassing, really. But that's the case. So I think, it's not so much people knowing about the pandemic. It's really like, how do we get people to care? Because, the typical person who dies of an overdose is not who you think it is. It's not necessarily people in our downtown east side. It's our fathers and our aunts and our cousins and our sisters and our brothers who are dying of overdoses. But we really need to find some way to make that connection.
Great, thank you. I am just looking to see. Oh, here's another question. Do you have a recommended reading list? There's so much information. I think it would be helpful to receive direction in this area. Thank you.
I think what I could maybe do, because in the interest of time, I wouldn't be able to go through that right now, but I could maybe provide a few resources afterwards.
Okay.
Thanks.
You're welcome. Thank you.
Also, some of the cultural safety courses that have been talked about have extensive reading lists. So SANYAS, Indigenous Cultural Safety Training, for example, or Cancer Care Ontario has a great cultural safety training course, and the one mentioned in the chat. So if you go to any of those, you will also see reading lists. Thank you.
Okay, that's great. Thank you, Nell. So I think we're up for time, and we have to move into the next area. But before we do, I'd just like to say how thankful I am for your presentation, for you, for the work that you do, and just to tell you how proud we are at the University of Waterloo that you started your post-secondary education with us, and we've never forgotten you, and we hope that you will be with us many more times in the future. So I look forward to the next time that I see you, and thank you so much for being here.
Thank you, Jean, and I want to raise my hands to you and all of the other panelists and recognize you for your hard work. Miigwech.
Which nakumek.
Thank you so much, Dr. Weissman. What thoughtful approaches are being employed under your leadership. You're providing such interesting insight on such an important issue for Canada, and BC working with you is really leading the way. Like Jean, I'm so proud that you are part of our family at the University of Waterloo. So echoing thanks from my side as well. Thanks for joining us today.
Thank you.
And I'll just mention a few things about Jean, just to tie things to Dr. Wyman talked about Jean being a leader in our community. So Jean is actually currently a member of the Mayor's Diversity, Equity and Inclusion Task Force in Kitchener, alongside all her duties for the University of Waterloo. And she's also a member of the Wellbeing Waterloo Region First Nation, Métis and Inuit Advisory and Advocacy Circle. So very, very much tied into leadership, not just for the University of Waterloo, but also for the community. She's been actively involved in Indigenous ceremonies and advocacy work for Indigenous people outside of our university and in fact nationally. Jean is really passionate about her work to implement decolonization in the University of Waterloo and in the academy generally. So Jean, we're also really pleased to have you here as a member of our community and leading us in these efforts. And you're gone off screen, so I'll just say thank you like this, Jean. So we're now ready to begin the panel session, and it's such a great pleasure to welcome Trevor Charles, who will be moderating the session. Trevor will introduce the speakers, but I'd like to say a few words about Trevor before we start. He's a professor of biology in our biology department. He's a bacterial geneticist. Trevor did a BSc in microbiology at the University of British Columbia, and then did his PhD at McMaster University with postdoctoral work at the University of Washington. He held a faculty position at McGill University before we were fortunate to be able to attract him to his current position at the University of Waterloo. He's now a professor here, and he's also the director of the Waterloo Center for Microbial Research. He's developed many innovations, and his website will list them all. But I wanted to mention particularly one that has been acknowledged globally and has won him many prizes, and that is the use of waste methane to create renewable bioplastics. His research broadly focuses on microbial analysis, and with a particular focus on agricultural and environmental challenges. Trevor, thank you so much for leading this panel discussion, and I'll pass it over to you to introduce the panelists and the topic of the panel discussion.
Good. Thank you, Vice President Dean. I am grateful for the opportunity to be involved in this important conversation. Today, we have three panelists to lead us through this dialogue. And I hope that through these discussions, we will identify opportunities so that we come out of the pandemic stronger and more resilient before. Before we start, really, after that outstanding keynote, really there is so much that we can say. But I want to say just a couple of words about this whole idea of global pandemic and let's think a little bit about what that means. And here I'm speaking more as a microbiologist. So a tiny microbe that we cannot see has upended and disrupted our entire way of life on a global scale. So I'm a microbiologist, more specifically a microbial geneticist. And microbiologists know about the power of the microbe, and geneticists understand the power of evolution. And we are all witness to this through this SARS-CoV-2 virus and the genetics through the variants of concern. In my research work, I focus mostly on the power of good microbes, like the ones that help make plants grow better and protect them from disease. But the global pandemic really is a reminder, perhaps a hard lesson, that we need to pay attention to what science is telling us. Rather than turn away from the science, we need to use science for good. We can learn how to be good scientists. We can all learn how to be good scientists, and it will serve us well, not only in dealing with pandemics. I would like to now introduce the three panelists. I'll introduce all three of them, and then I'll have them provide their statement, and then after that we will take questions. So our first panelist is Ruth Cameron. She is the Executive Director of the AIDS Committee of Cambridge, Kitchener, Waterloo, and area. Ruth is a PhD student at Wilfrid Laurier University in Community Psychology and the Executive Director of the AIDS Committee of Cambridge, Kitchener, Waterloo, and area. She is a member of the Ontario Advisory Committee on HIV/AIDS. Ruth's intersectoral health equity work engages intersectionality as framework for systems-level interventions in health equity. Our next panelist is Calpita Gaetande, a health promotion and evaluation specialist, campus wellness here at University of Waterloo. Calpita graduated from the Master of Public Health program at the University of Waterloo in 2013. Her public health experience encompasses health promotion, knowledge translation, program planning, implementation, and evaluation. As a clinician in India, she has done community work, community building work while practicing medicine. And finally, we have Dr. Ebele Mogo, who's a researcher at University of Cambridge. She's a graduate from University of Waterloo, BSc in 2009. She is a doctor of public health whose training spans community and behavioral health, health systems and policy, and biomedical science. Her work applies research to shape the implementation, innovation, and investment landscape for a healthy planetary future. At the University of Cambridge, she researches how African and Caribbean cities are changing and leverages points for shaping their urbanization in a way that creates improved health outcomes. So we have really an outstanding panel here. And I'm very much looking forward to this conversation. I will first call on Ruth Cameron to give her presentation.
Okay, so I would just like to start off today by thanking the University of Waterloo for bringing me in to participate with these other panelists and with Dr. Wyman on this presentation, talking about the COVID-19 pandemic, really focusing on disparities. I think with a perspective that allows us to think about lessons learned during a global pandemic. I'm really thinking about this in a very pragmatic sense rather than an academic sense based on my experiences throughout the last year. So very much wanted to just raise points in hopes that they could be further explored in the ensuing discussion today. So, but just a very brief agenda in terms of what I would like to discuss with you. Basically, I wanted to talk about this through the lens of Aqua. It is an organization, yes, that does focus on HIV/AIDS, but in doing so is very much focused on health equity. And I like to think of it as perhaps one type or one model of highly effective health equity intervention, not because of the focus so much on HIV/AIDS, but because we are very much a community-based, health equity-focused organization. Next, I want to think about the framework of a tool called the Health Equity Impact Assessment, something that we often employ in public health approaches and community health approaches for practitioners working with vulnerable communities. And how do we make that approach, that lens, embedded, pragmatic, something that is woven throughout all of our practices, policies, procedures when we work with people in communities to improve health. Last but not least, I want to think about some models of service delivery that involve either locations that are integrated service pathways or care continuums, where multiple social, community health, and neighborhood programs are in a service hub for ways to work on public and community health. But also I want to think about how we move into vulnerable communities, how we work in vulnerable communities to deliver public health and community health. So I want to tell a little bit of a story, and it's going to be a bit scattershot regarding the early days of the pandemic through my lens. Prior to the pandemic being declared, something that I was dealing with was both my work as an executive director of a community-based organization. Over the year prior to the pandemic, we had established an additional 4 clinics at our organization, in addition to our health promotion and prevention programs, which focus on primary, secondary, and tertiary prevention for the communities that are most vulnerable to HIV. Now, when it comes to HIV, what we have supposedly, and I say that a bit sarcastically, is an elimination strategy where we are apparently, according to goals that we set at UN/AIDS, the World Health Organization, at the national level in Canada, and at the provincial and territorial level, working towards elimination of stigma related to HIV, so that people who are living with it are having very full stigma-free lives where they're focused on their wellness. And we are working towards elimination so that the populations who are disproportionately impacted, there will be 0 new infections. I'm going to circle back to that elimination strategy point. In addition to that, we're supposedly focused on not only on this prevention, but on creating service hubs where several clinical programs can happen and create barrier-free access for the communities that are most vulnerable. Again, I'm going to circle back to that idea. So through this lens, at the start of the epidemic, when news started to trickle in, when experts were still also trying to work out information related to the virus, its severity, its transmission, what should be the public health messaging. My first thoughts as we started to debate whether or not masking was important, when we started to ask about what could be done, was that we needed to prioritize those who were most vulnerable and actually focus on emergency housing and emergency shelter as one of the first pieces in terms of containment to mute the severity of the epidemic. Unfortunately, what happened in Vancouver, that really excellent measure with the acquisition of hotels for individual rooming and housing, did not happen across the country. And it didn't happen right away locally either. So when we started to plan our approaches, we were still having conversations that were kind of debating all of these aspects of the social determinants of health. And also still explaining to some degree what they are. So focusing perhaps on race, not racism, focusing on disability, not ableism, focusing on what we believe to be individual characteristics of people from most vulnerable communities, as opposed to the actual structural barriers that these communities were facing. So, you know, if we reframe our thinking about social determinants here, we can see what we're dealing with in this pandemic. Unfortunately, there were conversations about whether perhaps there was actually racial differences happening from individuals who were in leadership and decision-making positions in Quebec with regards to the entire province's public health, as opposed to looking at the structural barriers, the racism, the ableism, the lack of a national food policy and a national housing policy that created the vulnerabilities for the communities that have been most disproportionately impacted by this pandemic. Something else that I want to focus on is some of the lessons we've learned in the past that didn't make it to the forefront in that first wave. Lessons we know about how people with privilege were moving from the influenza epidemic that happened in the early 1900s. Lessons learned about the need for an actual elimination strategy when it comes to when it comes to viruses from HIV. Lessons about preparation and how the SARS epidemic led to a federal agency focused on outbreaks and epidemics, and how even though we had that national agency, we didn't have the PPE at the ready at the start of this epidemic, and bring all of those lessons to our approach when it came to COVID-19. I've talked about social determinants, and I've talked about an elimination approach as important when it comes to dealing with outbreaks such as these. But the other thing that we had discussions and arguments about while this was unrolling was data. Unfortunately, there was still a refusal to collect disaggregated data at the start of this epidemic. And while we were wasting time on that, the communities that have been most disproportionately impacted, Indigenous communities, Black communities, non-white racialized communities, undocumented workers, have been bearing the brunt of this pandemic. All of this to say that I think it is important that we take our current breadth of lessons learned at this time and really think intentionally. We've been using the phrase, I think, so much across Canada for different aspects of structures about building back better. So thinking about our focus and our health messaging around individual behaviors, as opposed to bringing in broad, widespread measures intended to protect large groups and swaths of people, expanding the resources available for public health at the national, provincial and territorial, and local regional level, developing connection to the community-based organizations on the ground that have trust with vulnerable individuals in underserved communities, and thinking about the structures that mount our public health response. Something that I think bears mentioning at this time is a concept called the viral underclass. So if we're thinking about social determinants, we really should be thinking more about all of the communities who are most structurally disadvantaged, and how COVID, how other outbreaks, and how other inequalities show that it's the same communities again and again, whether we're talking about the drug poisoning crisis, whether we're talking about COVID, whether we're talking about homelessness. Our lack of an overarching kind of anti-racist and anti-oppression analysis is something that we need to need to bring in as we are trying our best to keep people safe at a time when something that is structural, that is happening, that we're not acknowledging in our approach, is an actual intentional state abandonment through dismantling the welfare state and our services. So what I want us to think about is how every facet of our public health response needs to be informed by community-based expertise. And as people who deliver healthcare, advocacy is necessary all the time. And that we need to expand our understanding of health equity and universality when it comes to our healthcare and Medicare in Canada. So thank you very much.
Thank you, Ruth. One of the things that really stood out for me there as you're finishing up is lessons learned and building back better. I think that through the resilience that we all gain through the pandemic, those are going to be important words that we pay attention to. So we will have time for questions after all of the opening statements. So thank you, Ruth, for that, and we'll come back to you towards the end of the session. Now I am going to call on Calpita Gaetande to give her statement, and I'm looking forward to your presentation.
Thank you, Trevor, for that introduction. I'm going to share my slides now. And could you just let me know when you can see them? Can you see them?
Yes, we can.
Yes, thank you. Yes, and thank you so much, Dr. Wyman and Ruth, for your presentations, because all that you've said ties in very well with what I have to say today. So my presentation today is focused on COVID-related disparities and the importance of ensuring health equity for us at the University of Waterloo. So does disease have color? That's the question. I mean, I don't need to stress that as much. The previous presentations have already said a lot about this. But let's see some stats here. By August 2020, 22% of all COVID-19 cases in Saskatchewan were linked with an outbreak in the far north, in a community with a relatively high concentration of Indigenous peoples. In Toronto, racialized populations represented over 80% of COVID-19 cases, despite making up only slightly more than 50% of the city's population. These racialized groups, which were overrepresented in COVID-19 cases, included Black people, Middle Eastern, West Asian, Latin American, South Asian or Indo-Caribbean, and Southeast Asian people. Similar patterns are seen across Canada and globally, including Nordic countries and the UK. Here, the article on the left shows vaccination rates for Black people in the United States to be half that of the white people, and the gap for Hispanic people is even larger. The article on the right shows wealthier Toronto neighborhoods with lower COVID-19 rates have significantly higher vaccination rates than lower income neighborhoods with more risk. Now, I could spend an entire day or days, in fact, talking about disparities in health and not just COVID related. But today I will focus on the reasons behind these disparities and what we can do about it at the University of Waterloo. So these disparities that we saw are avoidable and unjust differences in health outcomes that adversely affect marginalized or equity deserving groups. Note that these are avoidable and adversely affect certain marginalized groups of people and therefore unjust and unfair. And these disparities are systematically linked to economic and social disadvantage. A massive body of evidence links disadvantage, social and economic disadvantage, with avoidable illnesses and premature death. Now, these differences are so glaring because they can be mitigated or avoided at the social level through social policies and through cultural change brought about by education and advocacy. So let's take a look at the factors that contribute to these disparities. And Ruth already talked and introduced the concept of the social determinants of health. These are called social determinants of health in public health research. And these are individual social, economic, and environmental factors or conditions that are largely outside of one's individual control or lifestyle choices. And I will not read out the entire list to you in the interest of time, but please note that the visual here refers to Aboriginal status, which is a term no longer used. It should be Indigenous status. And also sexual orientation is not part of the list, but is a social determinant of health. Now, these determinants can cause economic and social advantage or disadvantage depending on someone's relative position in the social pecking order, an order in which individuals or groups can be stratified by their economic and social resources, as well as race, gender, ethnicity, religion, sexual orientation, disability, etc. Now, when these factors cause discrimination, disadvantage, subjugation, or oppression, they create systematic barriers for the equity deserving groups and lead to inequities in accessing services, resources, opportunities, and therefore lead to disparities. Now, these factors can adversely affect every aspect of life, including education, employment, lifestyle, living conditions, and ultimately health. And as you see from the slide, 50% of life factors are not in our control and are the largest predictor of what makes people sick. We also see that access or lack of access to healthcare system is 25% of what makes people sick. And when we think about health and wellness on campus here, we usually think of access to healthcare, doctors, counselors, etc. And even though this is very important, we may perhaps need to start thinking about what barriers some of our students and employee populations face in accessing not just healthcare, but other resources in education, research, employment, etc., because of the social determinants of health that they face. And the bigger question is, what do we do about these disparities? One of the ways to reduce health disparities would be by focusing our conversations on health equity, which is ensuring fair distribution and access to opportunities, programs, services, and resources in all sectors of life, with the goal of helping everyone achieve the highest possible standard of health for all. Now, special attention does need to be given to equity deserving groups because they are at the greatest risk of poor health outcomes. And it would now be important for us to frame our health equity conversation within the broader equity, diversity, and inclusion lens, as EDI, equity, diversity, inclusion, is one of the goals of the University of Waterloo's strategic plan. So what is EDI? So as you see on the slide, diversity means all the ways in which people differ. Here we also need to think a bit deeper about what kind of diversity we're talking about. Now, if you live in Waterloo and your family lives in London, or you completed your undergrad in 2001 and your sister completed it in 2005, that's diversity too. But this diversity may still be homogeneous in terms of privilege. We really need to think about whether our diversity conversation focuses on differences in power, prejudice, and privilege, differences that perpetuate discrimination, subjugation, or oppression. Are we talking about diversity that matters? And to talk about diversity that matters, we really need to focus diversity conversations on in how that diversity creates disparities or unfair and avoidable outcomes in education, health, and other sectors of life. Now, equity, as you see on the slide, means fair treatment, access, opportunity, and advancement for all people. We need to make an important distinction here, though, between equity and equality. Making things equal for everyone and providing the same opportunities or access to everyone may still not help individuals, certain individuals, achieve the optimal outcomes in any sector. Remember that equity is needs-based and that these individual needs differ based on the various inequities that they face, that different groups face, due to the specific social determinants of health. So think about what kind of individualized access to services, resources, opportunities would different students and employees need based on different inequities that they face. Now on the slide again, you see inclusion is a variety of people having power, a voice, and a decision-making authority. The important thing here is not just inviting people to the table, but these people having the opportunity to co-own the table. Inclusion also means being valued for who the person is without being marginalized in any way. It is creating a safe space where people feel like they can express dissent. It is a matter of being valued for their perspectives and their lived experiences. So it's important for post-secondary institutions to ensure that EDI shapes their governance, teaching, learning, research, and community engagement. So why is that important? Well, first of all, it's just being human. Asking to make a business case for why someone should be treated as an equal human being is deeply dehumanizing. EDI also creates psychological safety, feeling of being valued and heard. It helps mobilize innovative ideas and talent, helps reduce inequities and disparities in various sectors. And perhaps most important would be, it helps enhance both students and employees' sense of belonging and make sure everyone's views, beliefs, and values are integrated in decision-making. The National College Health Assessment data indicates that between 2016 and 2019, there was a decline in the percentage of Waterloo students who reported that they felt part of the community. The scale and complexity for post-secondary institution can result in a sense of fragmentation, disconnection, and isolation. Now, it is widely acknowledged that employees as well will feel more productive and impactful when they feel cared for, empowered, and valued, and that in a university setting, this productivity is directly concerned with student experience, satisfaction, and well-being. Now, before we start any of this work at the University of Waterloo, Aiko Bethia, who's the founder of Rare Coaching and Consulting, in her podcast with Brené Brown, stresses that EDI work is leadership work, period. And Dr. Wyman has already alluded to that. You do not really necessarily need to be a director or manager or in a leadership position to start this work, though. It does require you to be vulnerable and to create a space for EDI work to happen in your unit, department, or in any initiative that you're working in. The other thing is intentionality is very important. Is the intention behind doing this work serving the equity deserving groups who are the most harmed in society, or is it serving the purpose of some corporation or institution? Important to ask this question. The third thing is this work should be co-created and co-led by people with lived experiences. Organizations should be able to extend that invitation to them and be willing to lead by them. ICO also cautions against an action bias, which is the need to solve and fix a problem or issue fast. And this bias is usually driven by those in privileged positions because of their discomfort and vulnerability. So it's important for leaders to slow down and listen. Also beware of the horizon conflict. Different people doing this work have different senses of urgency, different concerns and timings. This is not because they don't have shared goals, but because each person might have different responsibilities for different horizons. So EDI work really is both transformational work and transactional work. So as you see from the slide, transformational work is about transparent, authentic leadership and governance committed to change. It's relational work. It's asking yourself why EDI is important to you and your coworker or even your family member. It's humanizing EDI. It's empathetically listening to stories and making connections with people. It's also consulting with equity deserving groups, asking them what their concerns are, listening to that and applying it in the work that you do. And this kind of change has the potential to lead to sustainable cultural shift. Transactional change is about operationalizing EDI in institutional values, job competencies, performance management structures. It's mainly about measuring and counting progress. It's more compliance driven and may or may not lead to culture shift. But the important thing is it both needs to be done in tandem. So transformational change includes components of transactional change. And so you're aggregating and disaggregating EDI in different ways and understanding it in different ways. So in the words of Jesse Venti, a First Nations Canadian arts journalist, humans should learn from nature. In a forest, for example, a variety of trees stand singular, but underneath the soil, the roots are intertwined and interdependent. When roots are not holding on to each other, trees tend to fall over easily. Humans need the same root structures in the form of diverse, inclusive, and equitable communities. Venti says, Nations and countries that were formed of colonialism were not founded with equity, diversity, or inclusion as fundamental beliefs, even though their constitutions state that they are about freedom and equality. We have inherited ideologies, systems, and structures that were exclusionary, unequal, and inequitable right from the beginning. Institutions and organizations are now becoming increasingly diverse. If an institution needs to survive in the future, we have to undo centuries of exclusion and inequities. So building a diverse, inclusive, and equitable community is not a choice anymore, but is an urgent need. Thank you.
Thank you so much, Calpita. Some of the words that you said early on, does disease have color? I think that's something that has been exposed by the pandemic. This morning, it really struck me. I saw, I think it was on Twitter, those pictures of people lining up for vaccines in hotspots.
Yes.
And, you know, taking time off work, not getting any pay for that, and in many cases not getting any vaccine. I mean, I think that is an example of something that really underscores how disease does have color in Canada. So I would like to move on to Dr. Mogo, who will give her statement, and then we'll have time for what I know will be a really productive discussion. Thank you.
Thank you so much, everyone. I've just really enjoyed listening to all the presentations. And first of all, I just wanted to say that it's such an honor to be back at Waterloo, because I went to Waterloo and it's just amazing to be back here talking on such an important topic. So I decided to title, because I know that Waterloo is very heavy on innovation and research. So I wanted to title my talk, Can Innovation Create the Systemic Shifts for a Healthy, Equitable Global Future? Now, I decided to also answer that question and say, why not? When I attended the University of Waterloo, it was around the 50th anniversary, and I just remember there were all these posters everywhere saying, in the spirit of why not? And so that question, why not, is what's sort of energizing my thoughts as we go through this presentation. First of all, I'd like you, as you're listening to me, to just think for a second about what really comes to your mind when you think about innovating in public health. Just take a second to think of what's the first image that comes to your mind. I won't be surprised if what first comes to your mind is perhaps a therapeutic innovation like a drug, or technological innovation, maybe a digital health innovation. And these are all forms of innovations, but I also hope that my presentation will start to encourage a broader sense of what it really means to innovate in public health as well. So first of all, innovations, or in the simplest way I'd like to see it, is that innovations create a multiplier effect in problem solving. And in public health, there are various ways that this can happen. It could be in investigating health issues. It could be in preventing diseases. For example, innovations in water purification, food safety, vaccinations have contributed to a lot of the improvements in health outcomes globally and increments in lifespans globally. It could be in addressing existing diseases, improving access. And I think that this is something that a lot of the conversations before me have already fed into a lot of the things I'm going to touch on, but which is great. So I think that this dimension of access is often forgotten, but it's a very underestimated but crucial component of improving equity. So these are things like innovative business models, design considerations, advocacy, and policy levers, without which we can't really take the solutions that we have to people who need them the most. So I want to think about this in the context of COVID-19 innovation. So when we think about it, we have innovations in disease investigation. Some examples of things that happened across the African continent, for example, there was an institute that came up with really affordable testing kits. We had drive-through testing stations in Nigeria. We had people working around dissemination of information in more culturally appropriate ways. This picture here shows a musician in Uganda being a part of the the sort of the process of trying to get the word out about COVID-19 and how to prevent it. Therapeutic solutions, the vaccines, digital healthcare, and then I'd mentioned access-related innovations, so cold chains for vaccine storage, repurposing of factories for mass production, for example. At the same time, I had originally titled this slide, named this slide, Innovation Can Also Create Inequities. And I was thinking about it. And I said, I'm going to say approaches to innovation can also create inequities. So I'm going to give an example from history. Around the 1990s was when the drugs for HIV/AIDS really entered the sort of the global market, antiretroviral drugs. And while they were being adopted rapidly in a lot of parts of the world that were high income, we had millions of patients, especially in sub-Saharan Africa, dying because the drugs were just too expensive. So there was need for an actual funding partnership with a focus on access to move from having these drugs that exist to making them available. So now, these things aren't so far-fetched. A lot of my co-panelists have talked about sort of the current implications. And I was also thinking around what are the gaps in COVID innovation lately. There's gaps in evidence use. So we have evidence around maybe how to protect yourself, but then it might not be in a language that people understand. It might not be in a medium that they have access to. It might not be coming from a system that they can trust because of these historical injustices that are quite global. Question of reach, gaps in use of preventive intervention. So whether or not it's affordability of diagnostics, how feasible is it for someone to distance if their job depends on them coming to your door? If someone doesn't have housing, how are they really going to maintain the level of sanitation needed to reduce their risk for a disease? Then we have gaps in vaccine use, so storage, distribution networks, funding. So this image here just shows, I got this image from, there's a COVID vaccinations tracker, and we can see sort of the discrepancies in the doses administered per 100 people when we look at different continents of the world. So these are the kind of questions that I think are the big questions, and I think that are what really reflecting on, especially in this time in the world. I think that this time has really put all of us in similar enough conditions to really start thinking of these common threads. And another concern around inequity is that communities are not starting from the same baseline, which is something that a lot of the panelists have echoed. There are inequities in the drivers of what we call pre-existing conditions, right? These pre-existing healthcare conditions are connected to pre-existing inequities in living conditions. And sometimes there's that disconnect between those two things. So there are inequities in distribution of healthy food, healthcare, housing, green and clean environments, safe, active transport. And if we don't start to integrate that thinking, that sort of that next level thinking into how we think of the so-called pre-existing conditions, we can't really make a headway in innovating in a way that actually creates solutions and drives health equity. So now, how then do we create equitable innovation in health? I was reflecting on this question and I had some thoughts. I was thinking of who might be here. So I thought there's going to be researchers, people who are aiming to shape policy, people who might be investing in difficult challenges, people who are innovators, especially in a university like Waterloo. So I had some thoughts that I would love to discuss more. The first of this is innovators who are focused on health impact. It's very important to remember that oftentimes innovations are not often designed for those who can, they're not often designed for those who need them the most. They're often designed for those who can afford them. And so it's important to start to ask, where are the actual gaps? And this means that we have to test our assumptions about what we think works, about the features of the context that should be incorporated in designing solutions. And this often requires innovative business and financing models and pairing with foundational infrastructure. So for example, in the picture here, you see that it's a picture of how solar energy, for example, can enable access to care, or talking about the vaccines. If a vaccine needs to be stored at under 70 degrees Celsius in a place that doesn't have refrigeration capacity, then we have to think of how to improve that capacity before even for them to access the vaccines. Another important thing that I think remains undervalued in conversations about solving problems is that a lot of innovation is happening on the front lines. A lot of innovation is already being driven by communities. And so really moving from viewing communities as recipients only to looking at communities as valuable partners in defining the problem, defining the scope of the problem, and really thinking about what actually works. What are the features of innovations that could work? What are the processes that could work? How do you think about it? What assets already exist in the community? So this is also a very important aspect of trying to solve problems innovatively. Now, I was also thinking about researchers. I think it's very important to normalize research that is sort of is outward facing in a sense, research that's trying to contribute some sort of value to social issues, health issues, because there are a lot of assets that exist in universities that are not necessarily being connected to impact. So normalizing research that engages diverse actors in articulating problems and solutions, bridging gaps between evidence development and use, normalizing using research to explore opportunities to look at things through this life cycle of health challenges and looking at opportunities and potential leverage points for impact. Normalizing, integrating this lens, like I'd mentioned, on the pre-existing inequities that are driving pre-existing conditions to get a more complete picture of what is actually happening downstream. And this will require advancement tracks that reward innovative ways of doing research as well, and the time and the relational capital that it takes to do that. But I think it also makes for a more enriching academic community as well. Now, I'm sure there's a lot of people who are listening to me that are also planning in some way to shape, inform, make policies. And the key opportunity and challenge here is, how do we start to make a value proposition for health and well-being as the goal of an economy, right? So moving from thinking that healthcare is just a sector to health equity as one of the ends of an economy. And that requires that we start using development matrices that a bit more system spanning, focusing on well-being, focusing on ecosystems and how they're doing. This will then help us to create the kind of fiscal space that we can use to innovate around pre-existing conditions, like I said. For example, if we want to ensure that people we reduce chronic conditions, which are a big risk factor for dying of COVID-19, for example, then we have to find a way and that political will to make it profitable, for example, for developers to invest in walkable, accessible communities, healthy grocery stores, healthcare coverage. These are sort of the starting points for really impacting on improved health outcomes. And this cannot happen without data systems that include equity matrices, because if we're just looking at averages, we're going to be missing what is really, really going on in communities. This also means that we have to start thinking about financial and legal innovations as well. Now, we've seen what happens when we put our money and our focus and our will towards trying to solve a challenge. A vaccine was created in record time. How about we start to think of how to do that for other pressing issues that are affecting underserved communities? So whether it's advanced purchases that make suppliers, that incentivize suppliers to create solutions for this kind of challenges. Then finally, this will also take more coherent policy making. So this example I gave, for example, if you have a trade sector that, for example, is trying to grow the economy by marketing a lot of fast food, and then you have a health sector that's trying to promote healthy eating, you see that those two things conflict a bit. So there's a need to bring sectors together to ensure that decision making is actually coherent, and then we're creating a kind of fiscal space to direct innovation in a way that's aligned with the inequities that we're seeing in communities. Finally, investors aiming for an impact on grand challenges. I don't know if you know, I'm sure most people will know at least one of the two people in this picture, but they're business people who are also active in philanthropy. And if investors will also need to start widening that scope of thinking about health innovation and investing in health to incorporate upstream drivers of pre-existing conditions. So like I'd mentioned, we have to start making it normal that when we're thinking about investing in health, we're also looking at the drivers of the, like we've called the social determinants of health. So I personally think that investments in healthy buildings, ensuring access to healthy food, and things like this are also investments in health. So investments in health are not only investments in healthcare. There's also a need for proactive financial instruments, like I'd mentioned. So the UN's COVAX facility was what helped to improve access to vaccines in a lot of countries, so that it wouldn't just be people who have the money that can purchase the vaccines. And we need more of those innovative financial instruments to direct our innovative efforts. There's also a need to think about how to support innovations that may not necessarily fit sort of a mainstream metrics, maybe like maybe a Silicon Valley model. There are things going on in communities already driven by communities, and there needs to be ways to identify and support what is already going on. And then going from scale and profit as sole success metrics of portfolio companies to looking at impact on health outcomes, as well as looking at the health equity impact. I think that if investors start thinking about, well, okay, this is an innovation that can impact on health, and how is it impacting on health equity as well, that would help us to start understanding how innovations could be made to bridge this gap between kind of what we know and the impact that we're making on those health issues. So that essentially brings me to my initial question, which is why not? I'm quite keen to continue the conversation, and thank you so much for having me. Quick thank you to everyone here, Dr. Anita Taylor, Jana James, Office of Research, my co-panelists, and everyone who's listening as well. Thank you.
Thank you for that, Dr. Mogo. I really love that touchstone of innovation that you used, because of course, you know, innovation seems to be around everything that we do at Waterloo. It reminded me really of some interaction I had with the late Calestis Juma, who was at Harvard, originally from Kenya, and a very innovative thinker. We didn't get a chance to meet him in person. He was going to visit us at Waterloo, but then took ill and eventually passed away. But he wrote a book called Innovation and Its Enemies, and also did a lot of work on agriculture in Africa. And one of the things that he used to always say is that instead of trying to figure out how to feed Africa, Africa should be feeding the world. Why isn't it? Would you have a response to that?
Wow. Yeah, I have heard of Calestis Juma. Why is that? I think, wow, that's a big question. I think that some of the whys are also connected to sort of the issues that we're facing with the pandemic. I think there's a need for long-term investments in, so let me give you an example. Actually, I was reading that about 1% of the vaccines that the continent is using come from the continent. So I think that there's need for more long-term investment. Obviously, we can talk about the history of why things are today. So you can talk about things like colonization, you can talk about all sorts of things like that. But coming today, moving from this sort of looking at the continent in a very short-term way to looking at sustainable investments in the community, sustainable investments in whether it's healthcare, manufacturing capacity, R&D development. I think those are the kind of things that will put us in a position to feed the world, which I think it should happen. I mean, there's such a great percentage of young people on the continent. There's so many human resources, but there have just been historical and structural factors that have gotten in the way of that happening. But I think that it is possible if we start looking at innovation in a different long-term and sustainable way.
Great, thank you. I thank all of the panelists for their presentations. We have some time now to continue our discussion, and I would like to invite everybody in the audience. If you have any questions, please post them. and we will include that in our discussion. But maybe to start off with, if we go back to Ruth Cameron, let's see where we can continue some of the discussion. So in your view, you already touched on some of this, but would you be able to continue some of your thoughts on how the pandemic has uncovered inequities in Waterloo region and surrounding communities?
I would start off by saying that I think that what has happened during the pandemic is that it hasn't, if I go back to we knew that this would happen, what we are dealing with are pre-existing, long-standing and historical inequities that have been actually further exacerbated, with disparities even widened more so during the pandemic, and that will continue to happen until we actually return to funding public health, look at widespread policy initiatives like universal basic income, and really, ramp up the expansion of policy and fund programs meant to permanently establish a baseline around affordable housing in Canada and a right to housing. So for me, when I look at this time, I can look both at the same patterns playing out, whether I look at a local context or if I look at a national context when it comes to COVID-19. Here in our region, there was a need, as there was at many levels in Canada, to advocate for the type of data collection that proved what community-based individuals and community-based organizations already knew, in terms of Indigenous communities, non-white racialized communities, homeless individuals being severely disproportionately impacted by COVID-19, and that we're not all in this together. So the time that we had to spend on that advocacy to ensure that a health equity response was mounted in terms of dealing with testing, in terms of dealing with supports in healthcare, and in terms of vaccine distribution, is time that we could have spent on controlling the first wave through an aggressive masking policy and an elimination strategy. I will say that our focus on vaccines in and of itself, Dr. Mogo, you talked about the inequalities in sub-Saharan Africa around vaccine distribution, and something that I think has been lost in a lot of our discussion about the vaccines is how the mRNA technology used to mount the really fast vaccine development response was created through some of the research that has gone into creating an HIV vaccine. Right? So we see these patterns repeating themselves through, we fail to follow an elimination strategy for HIV. We fail to look at the social drivers of HIV as a way to control the spread of HIV. And now we're, in not distributing the medications and focusing on funding the research to develop that vaccine, we've actually taken that technology, and the global north is disproportionately benefiting from the distribution, from the creation of that vaccine. So, these same inequities keep on being repeated through different social conditions, through different diseases. So, so I just see these repetitions and patterns, and seeing the need to come back to the bread and butter of focusing on the structural drivers as a way of dealing regardless of the health issue at play.
Thank you for that. I have a question here for Calpita. If you could ask a leader to take action on one thing for transformational change, what would it be?
Well, thank you, Trevor, for that question, and that's a really good question. And of course, I mean, the answer is never straightforward and it is definitely multifactorial, but the one step and maybe the initial step that any leader can take, or even anyone really can take within their own work, would be to develop meaningful relationships in building trust with equity deserving groups. And that could be students, employees, which includes, our QP employees, our staff, faculty, everyone. Just because we do need to tend to cultural shifts within our organizations, even before we start changing our systems and structures. And so, to change that culture, relationship building and trust building would be core to it. So I would say, let's take the first step there. That would be the best way to start.
Great. Thank you for that. Dr. Mogo, I think that one of the things that we sort of touched on a little bit was self-sufficiency in Africa. And I wanted to maybe give you the opportunity to continue some of that, maybe in the context of vaccine manufacturing.
Absolutely. So I mentioned earlier that about 1% of the vaccines being used on the continent come from the continent. There's a need to essentially, I personally think that there's a need for investments that encourage us to own and be self-sufficient. And I know that a lot of African leaders, especially with seeing that when you have a crisis, most countries look out for themselves. So a lot of countries, African leaders have come together to try to move that 1% up to 60%. Now, what is that going to take, right? So I know that the Africa CDC has been working to establish more vaccine production sites on the continent. I know that there has been talk about looking at, well, to have vaccine production on the continent, you also need to have a regulatory body. So there's been talk about establishing, I think it's called an African Medical Agency. And then how do you finance that? So I know there's also been a lot of will around getting the African Development Bank to help to finance some of the R&D and manufacturing efforts going on the continent. But let's remember also that it's not also about just about sort of the vaccines. It's also about, there's so many other health issues that are also a priority on the continent. So I also think that this should also be a question as well about, well, how are we transforming, say, built environments on the continent? How are we transforming healthcare infrastructure long-term so that it goes from sort of just a crisis response to a long-term response? So I think those are some of the ways that we can start answering that question of how the continent can be self-sufficient. Innovative financing, long-term thinking, R&D infrastructure, political will is very, very necessary. Yeah.
Yes, and I think those are all things that can be done. I mean, I think one of the things the pandemic has shown us is that when there is a will, that there is a way. We just have to decide what the priority is. Here, a general question that I'll pose to all of you, and you can all have a chance to respond. This is from the audience. Can you speak more about resilience? How can it be understood, and how can we nurture it, both in individuals and perhaps more importantly in communities?
I'm happy to speak if others would like to come in after me.
Sure.
I first want to trouble how resilience gets used by different people based on their social location. Resilience has become a word that I have a reaction to within my own work due to my social location and the locations of the communities that I work most closely with. When I think about it as a concept, resiliency is something that people often have to develop in response to trauma. in response to a setback, in response to various forms of inequality. I think that resilience can be a very positive thing in anyone's, if I take a look at anyone's life course, anyone's life trajectory, regardless of your social location, how many resources you have, everyone will experience negative experiences. Resilience is a very important thing for you to possess, but to be resilient, you have to be resourced. Whether that is about being surrounded by community, whether that is about having access to material resources that allow you to bounce back after a harm or a setback, they're all equally important. Whether it's about mental wellness and you having the resources, the space, and the time to attend to your mental well-being, those are all important things. However, our focus often on resiliency when we're looking at the delivery of healthcare and other services is about not preventing harm from happening in the first place. So when I hear nowadays when we talk about you need to be resilient is we intend to keep on harming you, so you'd better figure out how to be resilient. And I'd like to always, regardless of what conversation I have, think back to the structures of harm, right? Those structural determinants, what we resource in our society, how our pandemic, more resourcing is being given to an enforcement response than to building up all of the communities, the individuals through income redistribution, the institutions that should be funded at the government level to make sure that they are robust enough to carry us through this time of a international health crisis and keep us well in between this one and the next one that's coming because of the degradation we have done to the natural environment. So in terms of resiliency, I want to think about structures as much as we focus on the individual. How are we going to shift them and resource them to prevent further harm on communities and individuals? So we have to focus less attention on individual resilience and make sure that our institutions are non-harmful and robust enough that they can establish a protective factor for communities as they go through pandemic.
Thank you, Ruth. And yes, I'd like to add to that. First of all, thanks for really focusing that attention on structural resilience. And that is so important for sure, because right now at the University of Waterloo too, we have the President's Anti-Racism Task Force, which has started to look at these structures and systems and how we are going to be able to make that change in terms of structural resilience. And yes, you're right. Like, we can do a whole lot about developing personal resilience. But by the time a student comes to the post-secondary institution, they already have a certain personality, certain ways of doing things. It's hard to develop personal resilience when that's not been possibly developed right from the childhood. And so really, what change can we make in the way we do things to prevent that harm and race and discrimination, racism and discrimination from happening should be some of the focus that we need to focus on. So in terms of resilience, I would definitely echo what Ruth is saying, is that as an institution, I think we need to really focus our attention on prevention, as well as creating this equitable access to resources, services, and everything in order to promote that structural resilience.
Thanks both. As you were talking, I was actually thinking as well about, okay, so what were the examples of resilience in this pandemic? And a lot of what stands out to me is that communities that were able to be resilient often had some sort of investments before. So a lot of African countries that especially with the pandemic, if you look at it, you see that the responses weren't maybe the stereotypical assumption might have been that, okay, the response would have been the strongest in the UK or in the US. It wasn't necessarily the case. And why was this not the case? A lot of African countries had experience with infectious disease outbreaks. Some of them had experience with Ebola. So they'd had protocols, they had health system, they had responses. So you go to somewhere like South Sudan, and immediately you get out of the airport, people are already figuring out if you have pandemic, giving you information, there's signs everywhere. So what is done before a crisis lands is what really builds the resilience. A lot of the emerging economies that do have vaccine production capacity have had the technical investments in them, technical transfer before the pandemic. So I think, and then talking about networks, like a lot of people have been saying, sort of those strong networks, so that health is something that is in communities. It looks like the people it's serving. It's not really about hospitals, really. A lot of the drivers are things that have to do with communities. So building those kind of networks is also what builds trust in communities. And then when there is a pandemic, people are able to organize themselves in a way to deal with a lot of issues. So the way I see resilience is that it's really the investments that we make before. So this is our time to build resilience before something happens again.
That is a really interesting set of perspectives, I think, from different viewpoints about that resilience. I think we have time just for one short question. We're getting to the end of our time. Let me just see here. Okay, I will ask one more question, and that is to Calpita. How would you respond if someone doesn't believe in health equity?
Oh, Trevor, that is a hard question. And that definitely requires a lot of thinking through. And of course, I mean, the answers are never going to be a one-step answer. But here's one thing, right? If someone doesn't believe in something, that talks about someone's core belief systems. And if you look at vaccine hesitancy or water fluoridation, opposition to water fluoridation, especially in Canada and certain jurisdictions, if you were to take a look at what happened, it's very difficult to change core beliefs. So again, vaccine hesitancy would be the best example. Very, very difficult to change someone's core beliefs just based on research and evidence and data. What I would say to someone who doesn't believe in health equity, first of all, the way we should approach these kind of any kind of resistance would be to keep developing, keep engaging with these people. We need to have continual conversations with people who don't believe in certain concepts, right? So one of the things, I mean, I had recently attended a training by Betty Preece and Kayla Charles. It was about transforming privilege, prejudice, and power. And in that training, they talk about, certain core ideas that people hold. Most people who say they don't believe in health equity might have some fear associated with it, might have certain powerful ideas behind why they don't believe in it. So really the whole point here, as Betty Preece and Kayla Charles would say, would be to engage, connect, and challenge. So really, you keep engaging with these people, connecting with these people, and challenging certain belief systems. And so one of the questions really could be, well, if you don't believe in equity, why would that be? Like, you just engage with them, you have a conversation with them and get to know what their fears or belief systems are. And only then can we, and then, to keep developing those connections and not trying to necessarily change their belief systems, but more with more with a viewpoint of understanding where they're coming from. And then when you challenge, then, that person might be a little more receptive to it. So really, again, obviously I can't give a prescriptive answer to this. I don't think anyone would have a prescription for this, but I would say, engage, connect, and challenge. That would be how we would approach someone who doesn't believe in health equity or says that they don't believe in it.
Great. Thank you, Calpita. So I'm sorry to say that we are out of time. it seems like we just got started. I would like to thank all of our panelists. Really, so many ideas. This is clearly a continuing conversation, and I hope that we have opportunities to continue it in other forum. So now I would like to call on Vice President Dean for some closing comments.
Thanks, Trevor, and thanks to all the panelists. Lots of great discussion here. This is such valuable conversations. We've been talking about the pandemic, and my vision of the pandemic, at least from my viewpoint, and I'm sure that it's the same as many of our viewpoints, is that it has just been relentless. Day after day, like storm surges pounding on rocks on us day after day. I love this talk about resilience, and why not? We can make things happen. Why not? And the photo that you produced, Calpita, of the roots intertwined, such a great visual about how diversity, inclusion, and equity all work together. Thank you so much for all of you for your fabulous presentations. And a special thank you to Dr. Wyman for her presentation about both resilience and resistance of Indigenous communities in our current situation of COVID-19. Trevor, thanks for leading the panel presentation as well, and thanks for moderating the questions. I'd like to encourage everybody to register. We have 2 more events in our series of a year of COVID. The next one is about innovative research, and then the final one is concerning the transformation that we have made in the teaching and learning space. So please look out for both of them, and we look forward to seeing you all there. Thanks again to all our panelists for a really valuable conversation today, linking in with our work on anti-racism for the institution. Thank you very much, everyone.
Thank you.
Thank you. Bye.
Bye.
Thank you.